Yes.
I have no conflicts of interest to declare. I think over the next 10 minutes, so what I'll be trying to do is to discuss with you a very complex case, which is very relevant to the entire webinar today. So to start with, this is a case presentation which involves a timeline over 5 years period from 2018 to 2023. The first presentation of this child was at the age of 2 months with focal seizures and a right-sided weakness. He was a term delivery with normal growth and development. The brain MRI at presentation showed cerebral infarct and right posterior cerebral artery lesions, and a routine echo done for dilated big heart on X-ray, and also for looking for the cause of embolic stroke, showed severely dilated, poorly functioning left ventricle. So ejection fraction around 10–15%, significant mitral regurgitation. Therefore, the initial diagnosis, which began with focal seizures, changed to decompensated heart failure due to dilated cardiomyopathy. The cardiomyopathy screen was negative for infection, metabolic, and genetic etiologies. He was converted from a decompensated heart failure to ambulatory heart failure, and at around 8 transplant. It was an ABO incompatible, HLA compatible donor who was 1 year old and weighed 12 kilograms. The donor was matched for CMV and EBV. He received single dose of ATG at induction and standard immunosuppression with cyclosporin, azathioprine, and methylprednisolone. The transplantation was done at Freeman Hospital in Newcastle upon Tyne. At around 2 months, his immunosuppression was changed to tacrolimus and MMF. His subsequent post-transplant follow-up for almost 5 years was uneventful. He was looked after by a very caring set of parents. The compliance with medications was excellent. The immunosuppression levels were always in the target range. There was no evidence of graft rejection. The graft function was preserved on serial echocardiograms. There were no interval changes on ECG, and his renal function as well as rest of the biochemistry was always within normal limits. He recently presented in September of last year when he was 5 years, 8 months of age and almost 5 years post cardiac transplant. The presentation was to accident and emergency with acute throat pain, difficulty in swallowing, and a febrile intercurrent type illness. The findings noted in A and B were mainly of a unilateral left tonsillar enlargement and swelling in the left neck. He was prescribed a course of antibiotics and was discharged home. The cardiology team wasn't involved in the first at this point of contact. There was no response to antibiotics, and he was readmitted with worsening symptoms. And that's the stage when we were involved as the cardiologist looking after him. At that stage, the question was, could this be PTLD? His PTLD workup did reveal findings of high increased LDH, increased beta-2 microglobulins. He had become EBV positive. Graft function was still maintained on echocardiogram. There was no new pleural effusion or anything like that. And there were no new interval changes on the ECG. In order to investigate his neck swelling further, he had a head and neck CT scan and also a whole body CT scan later on. The head and neck CT scan showed soft tissue swelling in the nasal cavity, which was invasive and expanding into surrounding areas with erosion of the bones of the maxillary sinus. There were secondary right-sided deviation of the nasal septum, and there was left cervical lymphadenopathy. Following the initial CT scan of head and neck, he then underwent tonsillectomy, and the tonsillar tissue was examined under microscopy and for immunohistochemistry to confirm or exclude a diagnosis of PTLD. The microscopy of tonsillar tissue confirmed monomorphic B-cell PTLD. There was starry sky appearance of the biopsy specimen, and there were multiple nucleoli. So that's supposed to be a classical of B-cell PTLD, it seems. The FISH test was also performed to see genetic rearrangements, and the majority of the cells showed abnormal MYC gene, suggestive of Burkitt's type lymphoma. So the tonsil tissue biopsy or the histopathology of the tonsillar tissue confirmed the diagnosis of a diffuse large B-cell lymphoma, which was Burkitt's type, in a patient who had become EBV positive. He also had a whole body CT scan. There were no other major lymphadenopathies, and the rest of the CT scan was normal. He also had bone marrow trephine biopsy, and there was no evidence of malignancy. Once the diagnosis of PTLD was confirmed, the treatment began in stepwise fashion. Initially, there was a reduction in his immunosuppression, so his tacrolimus was reduced, and MMF stopped in discussion with the transplant team at Freeman Hospital. And then he was commenced on a course of rituximab. He received weekly courses of rituximab twice. The courses were the chemotherapy was then escalated to our COP regime and CHOP regime, and he received intrathecal methotrexate on 19-10-23. Now, this serial increment in his chemotherapy was in the context of a non-responsive PTLD and worsening clinical scenario. Despite all the attempts to treat his PTLD with incremental chemotherapy schedules, he developed multiple complications. And after his last dose of intrathecal methotrexate, he had problems with multi-organ failure. His picture was complicated by encephalopathy type picture, and he was transferred to PICU, where he was mechanically ventilated. He was very difficult to ventilate with bilateral pleural effusions and ascites. There was significant renal dysfunction needing continuous continuous hemofiltration. There was liver dysfunction. In addition, now there were signs of heart failure with impaired systolic cardiac function, a small pericardial effusion, which was a new development. And this is despite being on significant inotropes, a combination of adrenaline, noradrenaline, vasopressin. And he was also given a dose of steroids, assuming that it could be rejection. The entire course in his intensive care unit was also complicated by enterococcal sepsis. And eventually he sadly passed away 2 days after his stay in intensive care. So the discussion point for the rest of the webinar are PTLD masquerading as common childhood illnesses, because this child initially presented as something which looked quite similar to simple tonsillitis. We had lots of difficulties managing his aggressive PTLD, and balancing cardiac toxicity of chemotherapy versus graft failure with minimum immunosuppression remains a challenge in this scenario. And I hope the subsequent speakers will enlighten us about this issue. And also, my understanding of Burkitt's type lymphoma PTLD, the outlook is poor because it's very aggressive and does not really respond that well to therapy. So the challenges for future is how to improve survival in this kind of PTLD. Thank you. Any questions?
Thank you, Milan, very much. While we are waiting for questions, I can just apologize to my colleague Hakan Valander, who I haven't introduced to start with. So he's a moderator along myself, and he's a pediatric cardiologist working in Sweden.
Yes, thank you.
There are no questions in the box. So I think probably, Milan, you presented your case very clearly. Perhaps we can move to our second speaker, and if there is any questions regarding the case later on, perhaps you can answer then.
That's fine. Yeah, thank you. That's fine.
Thank you.
I'll stop sharing.
The next speaker is Professor Andrew Jennery. Please go ahead.
Hi,
Andrew.
thank you. Can you hear me okay?
Yes, we can.
Perfect. So thank you, Zdenka, and to the team for asking me to talk about EBV infection in the context of pediatric cardiac transplantation. And I think you'll find that with the talks that we've got today, there'll be a little bit of overlap. Milan's introduced the case really very nicely. Simon Bomkin, who will be talking after me, is our expert oncologist, and he will tell you about PTLD, and I'm really thinking about the bit before we get there. So I have no relevant disclosures. So Epstein-Barr virus, it's a human herpes virus. There are 8 in the family. They include viruses such as chickenpox, as herpes simplex type 1, type 2, as well as CMV, human herpes virus 6, 7, and 8. EBV is very common. It infects probably 95% of the population. So it's a very effective pathogen. And it normally infects very young children, and generally children who have EBV infection have very few or even no symptoms at all. So they might have a little bit of a cold, might be a mild fever, but often they may become seropositive, antibody positive, and nobody even knew that they'd been unwell. It's only when you get older that we start to see EBV causing diseases that you might be more familiar with, such as infectious mononucleosis or glandular fever, which is much more common in teenagers and adults. So how does EBV infect? Well, it infects the oropharynx, so the sort of mouth area in the back of the throat. And the EBV virus will infect the epithelial cells there, but it's particularly drawn towards B cells, which are part of the lymphocyte population. And it attacks and attracts or attaches itself to CD21, which is a marker of B cells. And through that marker, it actually enters the B cell where it lives and it causes infection. So it's an oral transmission, maybe by sneezing or certainly by kissing, which is why we see it in teenagers. And as I say, the infection initially is in the local epithelial cells and also the B cells, which are around the oropharynx, such as around the tonsils and other lymphoid tissue. Now, at that time, we have what we call a lytic phase, and we get high levels of virus, which is shedding into the oropharynx. And that's the point at which you are going to infect somebody else. Importantly, the virus drives proliferation of B cells. So once a B cell has been infected by the virus, 2 things happen. First of all, that B cell becomes immortal and doesn't die off. And secondly, it replicates. And if you think about infectious mononucleosis, what you have is a very intense proliferation of B cells, usually in the areas that B cells live, which is things like the lymph glands or in the spleen or the liver. And that's why you get this huge lymphadenopathy and also hepatosplenomegaly. Now, as I say, in young children, often the infection is asymptomatic. There may be a little bit of B cell proliferation, but quite quickly the infection comes under control. So normally this proliferation of B cells leads to an expansion of EB infected B cells. So if we take a blood test, we'll see lots and lots of B cells in the blood, and a lot of them will be clonal, so they'll be making one particular type of antibody, and they will all be infected by EBV. Importantly, some of those B cells will then enter the memory B cell pool and become what we call a memory B cell. Now, memory B cells are normal B cells. Everybody has them, whether you've had an EBV infection or not. And the memory B cell sits there waiting to see if it meets an antigen that it's previously seen, and it will make antibody against that antigen. It's why, for instance, if you've had chickenpox and you've cleared that infection and then you meet chickenpox again, you often don't become symptomatic because the memory T cells and the memory B cells clear that infection before it causes any symptoms. Well, the same is true in EBV infection, but of course the memory B cell actually is infected by that EBV virus, so it's carrying the EB virus. And this is what we mean by a latent infection. So anybody that's had an EBV infection in the past, if we look carefully, we could find EBV B cells that contain the virus, but aren't causing any harm. They're not causing any infection, they're not causing any symptoms, and they are controlled by T cells. So in EBV infection, although there is an antiviral response to control that infection, we are unable to eliminate the virus. So once you've had EBV, you've got it forever. And anybody that's previously had EBV, we will find EBV positive B cells 10, 20, 30, 40, 50, 60, 70 years later. They'll still be there. That early control of the infection is associated with the innate immune system, which is natural killer cells particularly, but also the CD8 and the CD4 T cells, which act specifically against particular EBV proteins. Now, over time, some of those T cell responses diminish and decrease, but again, there will be some memory T cells against that EBV infection, and they will persistently keep that EBV infected B cell under control and stop it from getting out of control and proliferating. So we can see that here. This is a slide that Ugo Offer, who's doing some PTLD research with us, has drawn. So you can see the oral mucosa infected by EBV. We get infection of the B cells. They are controlled by natural killer cells and T cells, CD8 and CD4 T cells. But some of those B cells become memory B cells, and they will circulate, they'll not cause any problems, but it is possible in particular circumstances that they could be reactivated, and then you will get further infection, but again that will be controlled by the CD4 and the CD8 T cells, so it brings that infection back under control. Now, I'm a pediatric immunologist. I do a bit of heart transplant immunology on the side, but my main job is looking after patients who have inborn errors of immunity. And we know that there are a number of genetic disorders which are associated with very severe EBV disease. And there's a whole series of those particular genetic disorders here. You don't need to particularly know about them, just know that they exist. And we know that those disorders that lead to severe EBV infection affect the function of the T cells or of the NK cells, and don't properly do immune surveillance and don't properly control either the EBV virus infection or indeed the B cells that the virus has infected. And we know that these patients who've got these genetic disorders can present with uncontrolled systemic EBV infection, so infectious mononucleosis or glandular fever gone mad. They can present with a very hyperinflammatory response known as hemophagocytic lymphohistiocytosis or HLH. They can present with very severe lymphoproliferation, and they can also develop a lymphoid malignancy such as a lymphoma. Now, I know as cardiologists that you'll be all fascinated with the embryology of the organs that develop in the cardiothoracic region. And of course, the pharyngeal pouch is a really important embryonic organ from which a lot of that development happens. And the most important organ that we can think of there, of course, forms from the third and fourth pouch, and indeed forms the thymus gland. Now, the thymus gland is the gland that makes T cells, and it begins to form at about 5 weeks of gestation, and by about 9 weeks of gestation, stem cells that are going to form T cells move from blood into the thymus, and over a few weeks they start to make mature T cells. Now, that's a process that starts very early on in embryology, continues throughout fetal life, but also into infancy and into early childhood. It probably continues beyond that, but the most important time is this early embryonic period and early infancy and early childhood. By the time you get to my age, I still have a thymus, but there's probably not doing very much. But in young children, thymic output is really important. And the generation of T cells, which are going to survive your lifetime and protect you from infections, is happening around this time. Now, again, as cardiologists, you'll know that if we have early stenectomy, often the thymus gland is big and it's in the way, and our cardiothoracic surgical colleagues, because it's in the way of the organ that they're interested in, the heart, they will often remove it. Now, it's not always a complete removal, but it may be a complete removal. And so we can think about how important that might be in different particular states. So at the bottom here, we can imagine a healthy person, they've got a normal thymus, and over the course of their life, first of all, new T cells are emerging. Some of those T cells become blue memory T cells. As they get older, the thymus starts to shrink a little bit. You don't have so much so much thymic output. And by the time they're in old age, there's maybe very little thymic output, and the majority of what they've got is mature memory T cells that have met antigen, fought against infection, and are just waiting for that infection to reappear and get rid of it again. Now, there are some immune states where the thymus is only partially formed, and we know that patients such as those with partial DeGeorge syndrome can have problems where, because the thymus is quite small in the first instance, you get a limited thymic output, a fairly low T cell count, and you probably get fairly early immune senescence with autoreactive T cells and a pool of memory T cells, but they don't get new T cells coming out for as long. We know patients, adults usually, who get myasthenia gravis may get a thymectomy at some point in adult life, but they've already done most of the important job of the thymus. They've already had a huge T cell output, so they've got a large pool of circulating naive T cells. And so if you take the thymus out when you're older, that may not matter. But if you are a young infant and you are relying on a huge thymic output early on, and very early on the thymus disappears, then that might be important for what happens to you in later life. For a long time, we've known that in the blood we can measure immunological abnormalities, but they don't seem to have any significant clinical effect on patients who've had early cardiac surgery. There was a manuscript published in New England Journal of Medicine just last year, which has readdressed this and looked at some adults who'd undergone thymectomy, and they found a number of things. They found that the T cells and the marker of new T cells was lower in the thymectomy group than it was in the control group. That's not a surprise. We've demonstrated that before. But for the first time, they were able to show that in patients who'd had a thymectomy, there was a greater mortality due to things like infection, cancer, or autoimmune disease. And when they excluded patients from that group who'd already had those significant infections, cancer, or autoimmune disease, then that significance became much more pronounced. And those that had a thymectomy were much more likely to die from these things than those that hadn't. So taking the thymus out early is probably not a great idea and does have long-term effects. Well, what about in pediatric cardiac transplant, which is what we're thinking about today, focusing on the child that Milan has just presented? Well, you can broadly think of two groups of children that get a cardiac transplant. Those who've had congenital heart disease, and it's quite likely that they will have had a thymectomy early on, particularly if they've had early surgery. And then those with cardiomyopathy, so if they are presenting later on, then the thymus has shrunk and it's not in the way, and they will not have had a thymectomy. But those that have been transplanted, like the patient that Milan presented, at only 8 months of age, they still have a big thymus. It was probably removed, and therefore that can be a sort of problem such as I've just described. Now, we know, because of previous research that I was involved in, that patients who've had a heart transplant as young children are more likely to get a diminished pneumococcal antibody response, and indeed pneumococcal infection, than those who were transplanted later in life. We also know, for some work that we've done here in Newcastle, that patients who've had a heart transplant, and particularly those who had congenital heart disease, are more likely to suffer from allergy early on than patients who've had a renal transplant. Now, this is interesting because, of course, both of these groups get cyclosporin or tacrolimus as immunosuppression, but it's only the cardiac children who end up having a thymectomy. The renal patients don't have a thymectomy, and so maybe that's important here as well. And then, very importantly, Uga Offa and Simon Bomkin, who's talking hopefully next, have done some work with us looking at post-transplant lymphoproliferative disease, which is what we're thinking about in this particular case. And in PTLD, you have a primary infection which becomes persistent. And in transplant patients, because of the immunosuppression that we give to prevent rejection, we are suppressing the T cells. Now, it's not a selective suppression, it's a blanket suppression which prevents rejection, but it may also suppress the T cells, which are normally suppressing B cell proliferation. And that means that patients either who've had EBV previously or who have EBV for the first time can get quite a sudden, rapid proliferation of B cells, which in this situation are not controlled by T cells, either because if they've had a thymectomy, they may not have those T cells there, but also because they're on immunosuppression, and that immunosuppression is going to damp down the response of T cells against those B cells. And Ugo did a very nice piece of work showing that patients looked at risk factors in our heart transplant population in our pediatric group, and patients who were EBV negative at time of transplant and then developed EBV after transplant, like the patient that Milan discussed, or indeed those that had congenital heart disease, were more likely to get post-transplant lymphoproliferative disease than patients who were already EBV positive or who had cardiomyopathy. Now, clearly, having cardiomyopathy can't really be something that protects you from EBV. And what is much more likely is, as I said just a little bit earlier, the patients with congenital heart disease had an early thymectomy, whereas those with cardiomyopathy may not have had thymectomy at all because they were older when they had their transplant. And what Ugo was able to demonstrate was that EBV negative patients were more likely to get PTLD. Patients with congenital heart disease were more likely to get PTLD. So in conclusion, I think we can say that EBV infection is a significant complication of pediatric cardiac transplant, that impaired T cell function secondary to immunosuppression and maybe following thymectomy certainly increases the risk of PTLD. So a two-hit hypothesis. Children that have had thymectomy but don't have a heart transplant generally don't get such bad EBV disease. So it's probably the immunosuppression on top of that that increases the risk of PTLD. And the management, as I hope you'll see in the following talks, is multidisciplinary. So I shall leave it at that and let hopefully Simon, if he's on the call, take the next talk. Thank you.
Oh, thank you. I can't see any questions as now, so we'll go on to introduce the next speaker, which was supposed to be Dr. Simon Bonken, but he's delayed. So instead, we'll go on to the fourth speaker on the program, which is Dr. Srinivasa Deshpande from the Advanced Cardiac Therapies and Heart Transplant program at Children's National Hospital in Washington. So,
thank you so much. Thank you to the moderators, to Dr. Reinhardt specifically for inviting me. And thank you to the AEPC. I'll share my slides and get them right. Okay, you can see the screen, okay?
Yes.
So what I'll try and do over the next 15 minutes or so, my timer right, is to go over some foundational principles around rejection in pediatric heart transplantation. I have no relevant disclosures. I think what we really need to acknowledge credit where it is due. And what I mean by that is we all know the story for heart transplantation and the early attempts at successfully palliating patients with a heart transplantation. And we also know that the limitations on their survival were mainly driven by lack of our understanding of both management of the immunology, management of rejection, prevention, and treatment related to that. And a lot of the successes now we have had are due to our improved understanding both of how to prevent rejection, how to manage immunosuppression, and when the rejection does occur, how to diagnose and treat it. And the survival improvement that we have seen in heart transplantation are related to a lot of factors, but I do believe that this is probably the biggest driver of survival and improvement in outcomes. For people who don't know, Simon Keith is a professional football player. He's a British Canadian football star who received heart transplantation prior to becoming a pro player. So he's the only professional athlete who's played with a heart, and he's on his second heart transplant now. And he's doing exceptionally well. Through the talk, what I do want to cover is some important principles related to rejection, clinical aspects of rejection, and then some impact statements along the way. How do we define rejection? Most simple terms, it's the body's immune response to a new organ, which it designates as a foreign body. Or in more complicated terms, rejection is an adaptive immune response mediated through T cells or through humoral immune mechanisms, targeting the cardiomyocytes, so the donor graft, or the vascular endothelial cells, again, within the donor graft or the heart. So it's basically, again, an adaptive immune response to this new organ that is deemed foreign. So to quickly jog our memory, and I promise this is relevant, so that's why it is worth jogging our memory from med school, which is the concept of innate immunity, which the body's ability to handle anything that's thrown at it, and adaptive immunity, which is more of a sophisticated learned mechanism. And as you know very well, the two main drivers for adaptive immunity are the B cells and the T cells, and we've heard a little bit of that already today. What does happen in an adaptive immune response, which is a slow response, is that both the B cells and T cells play crucial roles through either cellular mechanism of an immune response or through the antibody-mediated immune response through T cell and B cell respectively. But the end goal is still the same, which is to target the new antigen that has been recognized. And the new antigen in our case is on the cardiomyocytes, is on the new heart, is on the vascular endothelium of the new heart. So we have cell-mediated and antibody-mediated responses that can be generated to this new organ. Taking this just a bit further, just a quick reminder again, we already heard a little bit of this, which is, again, from the T cell colonies itself, we know that there are going to be some basic colonies of types of T cells. So the helper T cells, as well as the cytotoxic T cells. And within the B cell family, what we do have is the B cells, the activated B cells, or what are called the plasma cells, as well as the memory cells, which are extremely long-lived lymphocytes capable of responding to a re-stimulation or to an antigenic stimulation or just stimulation of the immune system itself. And then you have the natural killer cells. The ones in the blue, like we talked earlier, are related to the innate immune system and play some role. But again, we're predominantly going to focus on the T cells and the B cells that drive the rejection. We need to understand some other fundamental concepts around heart transplantation, and probably the two important things are the MHC genes. So we know that all nucleated cells will express class 1 MHC genes on them, or what we call HLA antigens. So these are going to be designated as HLA ABCs most commonly, and the most common ones. And in certain cells, specifically on the APCs or antigen presenting cells, such as the macrophages, B cells, dendritic cells, you have class 2 MHC genes, which will have antigens on them, which are designated as the DR, DQs, DPs antigens. So again, easy theme to remember, HLA ABCs belong to MHC class 1, and the HLA-Ds belong to MHC class 2s, without getting into too much detail. But these are important in terms of the antigenic responses, and we'll see why. So once we know that the donor organ has different antigens, and the recipient, the host, will produce a response to these antigens. And the response, again, to recapture, could be either directly related to T cell action, which is going to be designated here. The cell in the blue is the donor cell, or the donor APC, antigen presenting cell. And the host T cells are recognizing it quickly as saying this is foreign and reacting to it. Similarly, we can also have some indirect response through the B cells, which will generate antibodies that will attack both the donor endothelium vascular tissue, as well as the myocytes directly. So these are the principles how both recognition occurs as well as reaction will occur. We develop antibodies, all of us have the potential to develop alloantibodies, antigens against other human MHC antigens through blood product exposures, through homograft exposure, very important in Norwood reconstruction, for example, through pregnancy, infections, and previous transplantations. Just a vocabulary, presence of antibodies against class 1 and class 2 MHC antigens is called sensitization. An individual is sensitized to this. These are measured by various techniques, and the commonest use is the Luminex assay, which totals the panel reactive antibodies. So how many antibodies against what type of antigens do you have? Now, when these antibodies are specific towards donor antigens after a transplant, then they become donor-specific antibodies. So that's the nomenclature. So again, just to recap, rejection is an adaptive immune response mediated through T cell and humoral mechanism or B cell mechanisms, targeting the myocytes and vascular endothelium on the new heart. What are the types of rejections? So quickly, cellular rejection, as we said, mediated through mainly T cell, AMR or antibody mediated rejection through the B cell mechanisms, and either of these could be could present as a chronic rejection. We also know that the diagnosis of this hinges mainly currently on endomyocardial biopsy. So when we take a piece of the heart muscle, look at it under a microscope, we're looking for specific types of pathologies. And for cellular rejection, there is a gradation system which is commonly used, and 2 and 3R, which is moderate and severe rejections, are clinically very significant rejections. Again, reminder, these are mediated through the T cell. This is just a histopathologic example to show what no rejection here looks like compared to progressively more infiltration, the blue dots, the blue cells that you're seeing within the myocardium, and leading to disruption of the myocardium in severe rejection. So in the last panel, as you can see, there is pretty severe disruption of the entire myocardium, and the layout of the myocardium is gone. So this is a heart that is obviously quite sick. It will occur in 25-30% of patients in the first year, various grades, and is responsible for approximately 12% of the deaths within the first year post-transplantation. So clearly has a huge impact on transplant survival. AMR, on the other hand, again, reminder, mediated through B cell production of antibodies. This is again diagnosed through biopsy. We can look at both histopathology using H&E staining, as well as do specific immunostaining, looking for specific markers that tell us that there are either immune complexes present, or there are complement activation that has taken place, or the type of cells that are involved in the infiltration based on the antigenic targets. These are again complemented by testing for donor-specific antibodies circulating in the blood. Again, it is helpful to have DSAs, but not required to have DSAs, as we have seen sometimes when AMR can occur without us being able to detect DSAs, donor-specific antibodies. And AMR can actually present as a very hyperacute rejection and can get the patient quite sick. Again, a representative histopathology of this, showing progressive increase in the interstitial infiltration here in the myocardium, and also including the capillaries or the vessels. And again, this is special C4D staining showing the capillary staining of these cells as well as immunocomplexes within the myocardium. We also have one additional specific type of rejection which occurs in the OR right away after transplantation, which is called hyperacute rejection. And this is essentially the heart not waking up very well after the transplantation, rapid tissue necrosis, and death of the graft. It's a more of historical significance. We have had now dramatic reduction in this with the current level of cross-matching of the HLA antigens that we do, as well as the induction therapy that we use. But again, it can occur. Lastly, a quick note on the diagnosis itself, which is the newer diagnostic tools, which is the present use of donor-specific or donor fraction cell-free DNA. Very easy concept to understand. The genotype of the recipient is stable and different than the genotype from the donor. When you have cell injury to the heart muscle, that DNA, the donor DNA, gets released into the bloodstream, and we can detect that very, very easily in the bloodstream. And based on the fraction of the donor DNA present, we can tell you if there is injury to the myocardium or not. And we have shown in various publications that this is an extremely good marker of rejection, and it's also a good marker of ruling out rejection. So it has a very high negative predictive value in all ages. Quickly now, clinically, what are the risk factors for rejection? We know that age of the recipient is important. Female recipients are important. High number of HLA mismatches, Black recipients, and non-compliance with medical regimen is probably the most important part. In AMR, again, female gender is a risk factor. High PRS, so if you have preformed antibodies that are circulating, that's obviously a high-risk setup. History of VAD, history of infections, and retransplantation are all risk factors for AMR. Signs and symptoms of rejection are actually similar to heart failure, just like Milan was presenting at the beginning, which is any sign that is consistent with ventricular dysfunction, any sign that is consistent with increase in CVP, are consistently seen in rejection too. So again, it presents as heart failure. What we have very commonly seen is that abdominal pain, nausea, vomiting in a transplant patient always raises a red flag for us. So if you see a patient who has history of transplant and is presenting with GI symptoms, always have rejection on the differential diagnosis. And on echocardiography, it's very, very easy to detect. This is a patient with heart transplantation, now 2 years out, had baseline echocardiogram that had normal function. 2 months after this echo, she presented in the emergency room with cough, congestion, and an echo that looked like this, clearly a decreased function on the echo. And we tested her right away for other markers of rejection and treated her for acute rejection. So ventricular dysfunction, very easy to detect on the echo, and essentially for us is a gold standard as far as clinical diagnosis of rejection is concerned. So high degree of suspicion and early initiation of therapy is important. Within the last minute or two, quickly, I'll go through the principles of rejection treatment. Just focusing on this again. This is the antigen presenting cell. This is the T cell. And all of these various mechanisms that are involved in activating the T cell and the responses that generate the downstream effect, both through complement-mediated actions, direct cell lysis, as well as the B cell activation, are targets for our rejection therapies. So for cellular rejection, for example, for 1 hour, we don't treat. For 2 hours, we would use pulse steroids. And for 3 hours and above, we would use thymoglobulin along with steroids or OKT3 based at some centers. But again, we're targeting this interaction between antigen-presenting cells and the T cells. If we get sick, again, obviously may require ICU support and mechanical support or ECMO is needed to resuscitate these patients. If it is recurrent, then we would use some higher-end therapies such as basiliximab or alemtuzumab and photopheresis in the European centers. AMR, just as a quick reminder, again, mediated through B cells and antibody production. So the goals of AMR therapy are to reduce circulating antibodies. So in the plasma, you can use plasmapheresis or IVIG. Reduce production of antibodies, so target the B cells that are producing it. Rituximab is the therapy that's most commonly used. And we target the plasma cells by using daratumumab, which is, lysing the plasma cells that are generating the antibodies. And reduce cellular injury at the allograft level by, again, targeting the last stage of complement activation or complement fixation, forming the MAC complexes. And there we would use eculizumab to treat this last step of endothelial injury. This is a good resource for everybody to check in, and I think it's a good summary of how to manage acute rejection in pediatric heart transplantation. Impact of rejection. Once you do have rejection, we know it affects graft survival, long-term graft survival, And we know that AMR occurrence is associated with development of coronary vasculopathy, which further reduces the graft survival. So in summary, what I really wanted to focus on is that the principles of transplant immunology directly impact how we think about rejection, why rejection occurs, and how we treat it. Clinical suspicion and early treatment is really the key, but there's still a room for improvement, as we are seeing, because we continue to see loss of graft life after rejection. So there is research and therapy inventions that are required for better managing these rejection patients. Thank you again, and I hope this was helpful. Happy to take questions.
Thank you very much. That was an excellent talk. One question: how do you achieve a balance in immunosuppression in order to prevent rejection and not to cause PTLD?
Yeah, I think that's a $1 million question, in the sense that we know that as we've been hearing and getting a sense that every immune system is built quite differently, and we may have very different responses, but we have a blanket therapy that we currently use at blanket levels of immunosuppression. So what is truly required, one, is that the concept of minimizing the immunosuppression that is adequate to keep rejection from occurring is the key. And the second concept is whether we understand immunosuppression a little bit better. What is the residual function that is required for us to maintain a healthy immune system, especially in the setup of viremias, is a more important aspect there. So by that, what I mean is just measuring the trough levels of, say, tacrolimus or MMF or mycophenolate may not be an adequate representation of what immunosuppression has been achieved. So sometimes doing functional testing may be the way to do it. Obviously, that's not standard of care. That's not clinical standard of care right now. But I do suspect that within the next few years, we will get to the point where we can now customize the level of immunosuppression that we leave patients on based on their immune system, their immune responses, and the residual functional status that is left behind. Currently, as we said, we do it in a dumb way, quite dumb way, which is just everybody needs X amount of immunosuppression, and then only modify if the setup is there. Lastly, I'll say quickly, which is to the previous talk, as well as what we know from infection standpoint, which is how do we monitor and how do we modulate immunosuppression in the setup of a viremia, especially EBV CMV viremia, is again something we need to learn, because what is an inadequate immunoreduction in those patients is still not very clearly established. And we do have to learn a little bit more about that too.
Thank you. There are a few questions in the chat. I will read a couple, and then I'll leave to my colleague to read few. So one question from Luis Garcia Goreta, a colleague from Madrid. When do you consider retransplantation in repeat antibody-mediated rejection?
Specifically, when it's an AMR, antibody-mediated rejection, retransplantation results are actually quite poor. And what we do know is that these are the patients who have an extremely high tendency to generate an immune response, specifically an AMR, to the new antigenic stimulation. Because we share so many antigens amongst ourselves, even if we give them a new antigen, so new graft, it is very likely that the immune system is going to react, and sometimes react even more strongly to the new antigenic stimulation. So when somebody has persistent AMR, the two things we will try to do. One is to treat them as aggressively as we can with depletion therapies, so that we can wipe out their memory cells, their plasma cells as aggressively as we can, so that further production of antibodies for the current organ gets less and less. Not just a matter of filtering antibodies, that's not adequate. We really have to get to them. And the second part to that is then, if the patient allows us time, get to the point where minimal amount of circulating antibodies are present, and then think about how selective can we be to choosing the next organ. But yes, in general, chronic AMR, the outcomes of retransplantation are poor. And so we are somewhat hesitant to jump to that quickly. We will actively treat them for a long time with depleting therapies first.
And the next question from Jens Bomer. In a larger study on cell-free DNA after heart transplant, we saw many grade 2R rejection without any clinical signs and without elevated cell-free DNA levels. What is your comment about this?
So that is not my experience. My experience is that we have seen a lot of what we call quote unquote false positives, which is that there may be a lot more patients where biopsy was negative, but cell-free DNA was elevated. But to directly answer your question, when we do have grade 2 rejection without elevated cell-free DNA levels, two things are potentially happening. One, we do know the limitation between 1R and 2R rejection in terms of the histopathologic grading. We know that there is significant discrepancy in terms of inter-rater variability, as well as treating pathology as a gold standard itself. So I do think that we have to take that with a grain of salt. Just because the pathology came back as 2R and the patient's doing really very well, and you don't have cell-free DNA elevation, maybe there is not the myocyte injury that you suspect there is. Whether it's the residual injury or whether you're overcalling it is certainly possible. So in my view, that's not necessarily a false negative. That is not necessarily saying that you should have had elevated cell-free DNA and you don't. That's not necessarily a false negative. I would then question the gold standard, quote unquote, gold standard itself, whether 2R is truly a 2R. The other thing we do in those patients is surveillance, change the surveillance. So if the patient had a positive biopsy, we look at the history, we look at the risk profile of that patient, and we change the surveillance. At the very least, we may just change the surveillance in terms of cell-free DNA detection. And we might find that over time, within the next week, and again, you don't need too much time. Next week, you can repeat it. Next week, you can repeat it. And eventually, you may find that the cell-free DNA is also now elevating. Or we find that the cell-free DNA continues to stay low, then we don't need to treat it. We wouldn't modify the current immunosuppression for that patient. I hope that answers the question.
Thank you. And there is one difficult question from Ina, our Secretary General, APC Secretary General. Do you use TORC-attenuated virus to balance infection versus rejection? We don't, but let's see what do you do in Washington?
No, we don't. And that's what I was hinting at, which is, again, that there will be therapies and there will be, there will be other diagnostics that teach us about the residual immunologic function, whether it's appropriate, responsive or not, and whether that's the best way to look for adequate immunosuppression. We're not doing that. Certainly there is research going on in that field, but clinically we're not using that.
If there are no questions, I think our last speaker, Dr. Simon Bomken, is here. And Simon, if you're ready, the floor is yours.
Thanks. Can I check you can hear me okay?
The screen is yours, yeah. We
can
can,
hear you.
yes. Thank you.
Okay. Whether I can make you see the whole screen is the next question. Okay, do you see the whole screen?
Yes, we can.
Okay, perfect. Thank you, Zdenka. So, yeah, my name's Simon Bonken. I'm a paediatric oncologist at the Great North Children's Hospital up in Newcastle. And I work with Zdenka and the team to look after young children who develop PTLD following a heart transplant. So, firstly, I'd like to thank the organising team for the opportunity to speak to you today and just give you my perspective from hopefully a kind of fairly simple and understandable angle on PTLD, or post-transplant lymphoproliferative disorder, as you know from the previous talks. So we're going to have a little look through the incidence, the histopathological spectrum, how it can present, although often that will be to you guys rather than to myself. And then more my area will be diagnostics management. And then we'll have a quick think about kind of what we might try to do in the future around it. So statistics can be quite challenging in this field because numbers are relatively small, but broadly what we see is that somewhere around 10 to 15% of young people who have had an orthotopic heart transplant will develop PTLD following that transplant. This is at the higher end of the spectrum for other solid organs. So least frequent would be PTLD following a renal transplant, liver a little bit more, lung a little bit more. Small bowel, I think, carries the highest risk, but of course the number of small bowel recipients is really pretty tiny in comparison with other organs. Sorry, I'll just try and remove that. Okay, so of those, I'm sure you'll be aware, and there's been discussion, I know, about EBV and viruses already. So the significant majority of PTLD in children who have received a heart transplant will be EBV positive. So in a large study in the Lancet several years ago now, 87% of lesions, this is not looking at blood, this is lesions, so the lymphoma were EBV positive. In our own series, looking at 200 recipients between 2000 and 2015, and we identified 30 odd patients there. EBV was found in all of those lesions. This may vary a little bit depending on when that PTLD occurs. So a kind of classical view, if you like, is that it's higher early post-transplant. So in the recipients, in the children who develop PTLD within the first year following transplant, and a little bit less in those later. It's not clear how that interacts with other, for example, cytogenetic features of those lymphomas, but that is a broad kind of viewpoint. And of course, I'm sure many of you will already know that being EBV naive at the point of your transplant, and particularly if the donor is positive, so discordance there, presents one of the most robustly demonstrated risk factors for development of subsequent PTLD. Okay, so histology, I haven't gone as far as showing any pictures, largely because I couldn't interpret them very easily for you. But the definition of PTLD has become better and clearer over the last 10 to 15 years. So we're now using the World Health Organization's classification of hematolymphoid tumors, which was just updated and re-released in 2022. And this has a slightly new approach, so it recognizes the importance of the immunosuppressed state quite transparently, which previous, certainly earlier versions hadn't done. It recognizes that many PTLD lesions are very similar morphologically to other states, and so it recognizes them in the position of being like something else. And it specifically identifies the putative viral causation, so the associated virus with it. So we recognize that, particularly in relation to EBV, that you can get anything ranging from something that looks like glandular fever, for example, in an otherwise immunocompetent host, right the way through to something that looks morphologically indistinguishable from a sporadic lymphoma. Most commonly, that will be something that looks like diffuse large B-cell lymphoma, which is a more common type of aggressive or high-grade B-cell lymphoma in adults, relatively less common in children. Our more common sporadic lymphoma in childhood is Burkitt lymphoma, and we do occasionally see that. And then much more rarely, you can see Hodgkin lymphoma like PTLDs, and very, very occasionally, they're all B-cell derived. Very occasionally, you can see a T-cell derived. And then in the middle, you have something which is kind of in the middle, which is that it certainly doesn't look like normal lymphoid structures. Those have been destroyed. But it doesn't, neither does it look like a monomorphic PTLD. So it looks like a whole bunch of inflammatory cells, but they've clearly gone far beyond even an abnormal lymphoid reaction. They've destroyed the usual structures of the tissue. So we call the polymorphic and the monomorphic both destructive lesions, And then on the left-hand side of the spectrum, they're the hyperplasia and glandular fever-like as non-destructive. There's also this additional presentation, if you like, which is a fulminant PTLD, and that's the triad of fever, hypotension, and at least 2 organ failure. And that is usually or commonly in the setting of polymorphic PTLD rather than the kind of true monomorphic disease. So it wouldn't, and is an extremely dangerous clinical situation. So it wouldn't be fair to kind of view the polymorphic disease with anything other than respect. So diagnostically, we do some things. We do some simple blood tests often. So we want to know whether the kidneys are functioning well. That can often, of course, so you'll know better than me, be a problem for heart transplant recipients for multiple problems. But in this setting, what we're worried about is a clinical situation called tumor lysis syndrome, which is where these very rapidly progressive lymphomas are not only growing, but also dying very quickly. And they release various salts, particularly potassium and phosphates and proteins into the blood, and they can cause an exacerbation of renal dysfunction, and you have a downward spiral from there. Rapidly proliferating lesions can lead to rises in LDH, and that gives you a kind of sense of how rapidly the thing is changing. Beta 2, I should say microglobulin, I beg your pardon, is a product of B cells, and you can see a rise in that when you have a clonal proliferation of B cells, but just a word of caution that it's excreted by the renal system, and so if you have renal dysfunction, then you will get an abnormally high beta 2 microglobulin, so you need to interpret it with care. And we usually look at EBV titer as well to give us a baseline. It's not helpful in determining whether or not you have PTLD, because you can have a high EBV titer just because of your immunosuppression. We like to understand where things are in terms of imaging, and we often use ultrasound in pediatrics because it's quick and it's easy and it doesn't involve radiation and it doesn't involve the need for sedation or anesthetic for younger children. CT remains readily available in terms of ease of getting a child into a scanner, and it's so quick now that you don't usually need to use MRI. Of course, gives us often much more detail, doesn't have to involve the use of intravenous contrast, which can be nephrotoxic, but does require the child to lie still and to lie still for longer. All of these things, however, are proxies for really knowing what's going on, and what we really need to know, harking back to my previous slide, is what the histopathology is. And so we like tissue. We do not like fine needle aspirations, and historically that's been a challenge, particularly if the lymphadenopathy as a presentation is up in the neck, because ENT colleagues, particularly with adult practice, are very used to doing fine needle aspiration. They don't give us the morphological features which we need to make our diagnoses, and really we're looking for either a core biopsy or ideally an excision biopsy. But ultimately, this has to be done as a team sport, and we're very fortunate in Newcastle to have good collaborations between each of the relevant specialties, and I'm sure that that will be true of many of the institutions you work in as well. But that really is the cornerstone to effectively looking after these children. Okay, so if we make a histological diagnosis, then what are we going to do about it? And this is a stepwise escalation, if you like, in the majority of cases. So irrespective almost of what it looks like down the microscope, we're going to start with step 1, which is a reduction in immunosuppression. And I know that there's already been talks on that, and I'm really deeply sorry that I've not been able to be with you for the whole meeting. But yeah, of course, it doesn't need to be rehearsed here. The issue here is about balancing the risk of organ rejection against our risk from the PTLD. Nevertheless, even if you go on to higher levels of therapy, the importance of reduction in immunosuppression can't be overstressed. So that really is a cornerstone. As a basic strategy, we would like to do that and then wait and see what happens. And if that is insufficient, then we add in rituximab. And then we'd like to see if that is sufficient. And if it isn't, then we add in chemotherapy. There are, however, some situations where that is not the right decision. And predominantly those are where we have either a clinical concern about the child because they are already becoming significantly unwell from their PTLD, or it's because we know a little bit more about the pathology, and that tells us that this is not going to be a sufficient level of therapy and we need to escalate in response to the histopathology. So examples of that, and I suspect that different national guidelines will differ slightly on this, but certainly in the UK, most people would be pretty anxious about only using rituximab with a Burkitt-like histology. And in part, that is because of the speed with which Burkitt lymphoma can develop. And so reduction in immunosuppression needs some time, and you often don't have that time for a child with Burkitt histology. Another situation would be patients where, when we do our basic cytogenetics workup, which I've not talked about here, we identify something which we believe to be a risk feature, which is the cytogenetic hallmark of Burkitt, which is a translocation of the gene MYC. But we also see that in other types of lymphoma as well. And so MYC translocated, as we call them, lymphomas definitely raise people's level of anxiety. The discussion, for example, nationally here in the UK is not whether rituximab is enough, but it's whether low-dose chemotherapy is enough, or whether we ought to move on to a higher intensity of therapy just because of the MYC translocation. So those things might make you take step up in your therapy quicker, but they certainly don't remove the importance of the earlier steps. And then, of course, we have the situation in a relatively small but not insignificant proportion of patients where our earlier steps have been insufficient and they continue to respond to therapy. And then you get on to something which looks a little bit more like our intensity of therapy that we would use in sporadic lymphomas, because the standard PTLD approaches are all significantly less intensive. Okay. So with that strategy, what does it look like in terms of outcome? So probably the best data, certainly of relevance to our UK strategy, and I appreciate that many of you are not from the UK, but our UK strategy, which would be, as per the previous slide, reduction in immunosuppression, addition of rituximab, and then a chemotherapy called R-COP, so rituximab, and then 3 relatively low-dose chemotherapy agents, cyclophosphamide, vincristine, and prednisolone. The most helpful data of relevance to that is this American study where they used rituximab, cyclophosphamide, and prednisolone, but no vincristine for various reasons. And what that showed is that at 2 years, which is a meaningful time point in this disease, we have an event-free survival of 71% and an overall survival of 83%. And those events are a relatively even split mix of rejection, toxic events, and progression of PTLD. And so in thinking about how we deal with this, we are always trying to balance essentially those 3 risks. I mentioned earlier the study which we published a couple of years ago from our 200 cases, 200 transplanted children here in Newcastle. And we saw amongst all the PTLD there, so including the non-destructive lesions, we saw 19 cases of destructive PTLD, of which 12 were monomorphic, so 12 of them were diffuse large B and or Burkitt lymphoma. And in our experience, we had a 3-year overall survival of 94%, a 5-year overall survival of 87%. So there are losses in that survival rate outside that early period, and they continue to be from a combination of factors. At that point, it's often to do with organ dysfunction or other conditions rather than the PTLD itself. But you can get kind of ongoing troublesome patients who just go through multiple lines of therapy over protracted periods of time, and they can be very challenging. So if we've still got a bit of time, and hopefully we have, but Zdenka, please tell me to shut up when you need to. I thought it might be helpful just to think through a couple of cases which make points. These aren't the cases which have already been presented by Dr. Chowdhury, but some other cases. So presentation you'll know you had a child who comes into your cardiology clinic and you can see or feel lymphadenopathy in their neck, or they complain of something in their abdomen. When you examine them, they have an abdominal mass, or they have some imaging for some other reason and you see something in their chest. So these are quite common presentations. Less common and often more troublesome or worrying are the kid who comes in just unwell and febrile, or sometimes even worse, the child who comes in with gastrointestinal symptoms, and particularly when it relates to diarrhea and bloody diarrhea. And those children can be extremely unwell, and they can also be quite challenging to diagnose. Central nervous system disease is pretty uncommon, and it's pretty rare to have a child presenting with central nervous system symptoms. But if you do, PTLD has to be, sorry, I'll just pause while you have a
L'objet abandonné peut être immédiatement détruit par les services de police. Les passagers sont constamment priés de conserver leur bagage avec eux.
Sorry, I'll come back to you in a moment.
Simon, we have plenty of time, so please go ahead in your own speed.
Okay, sorry, just I wasn't sure you all wanted to hear the security announcement. Okay, so a 6-year-old girl who had hypoplastic left heart and had had a Fontan procedure, had a transplant at 5 years of age. I first met her 18 months following transplant when she presented with bloody diarrhea, and also was clinically becoming significantly unwell. So she had a number of investigations, but this is our diagnostic CT scan. And what you can see here for those of you who aren't kind of commonly looking at CT scans, over here we've got bowel with gas in it. These are some slightly thickened bowel wall loops, but the bowel here is filled with fluid. That's why you have a different attenuation to the air in those loops. But over here you can see that the bowel wall has largely been replaced by this very thickened small bowel. She actually also had an obstructive lesion up at the pylorus of her stomach, and that was biopsied and gave us a diagnosis of diffuse large B-cell lymphoma. So she started on a relatively gentle bit of chemotherapy, and then about a week later became significantly more unwell. So this is a repeat imaging now in a coronal plane. And you can see that down in the left iliac fossa, lots of things are improving. So we have a very rapid response to treatment. The pylorus of her stomach still looks a bit of a mess. But consistent with her unwellness is the fact that up here you can see free fluid around the liver, and then these locules of air around the liver. So she's actually perforated her small bowel. And this is not a terribly uncommon feature with aggressive lymphomas involving the bowel, because you can get them extending across the entire thickness of the bowel wall. And when you give an effective therapy, that bit of lymphoma just disappears and you're left simply with a hole. The other potential way to do that, to see this complication, is the corticosteroids that we use in reasonable doses can also cause gastric erosion and perforation, of course, but actually it's usually, particularly early on, that you've just effectively treated the lymphoma and you have a complication. So this young girl went on and had a laparotomy, geez, I forget now whether she had a stoma formed or a primary closure, but either way was pretty unwell on intensive care receiving chemotherapy, more from that perspective than the PTLD per se. But she was treated with 6 cycles of gentle chemotherapy and is now a long way off treatment and is a survivor. Okay, a second patient who makes a slightly different point is a 14-year-old girl with an idiopathic cardiomyopathy who had a transplant at the age of 10 years. And she had a small lesion identified on a routine annual coronary angiogram. And then that imaging was repeated pretty shortly afterwards. And this small lesion was now fairly obvious, I would say, here in the mediastinum. She was extremely well, completely asymptomatic, and I, hand on heart, say that maybe my level of concern about her, particularly as a young child, out of region where things then become a little bit more complicated, isn't or wasn't where in retrospect maybe it should have been. And we got to the point where actually when we then, although she was clinically still well, re-imaged her pre-chemo, she now had this really quite sizable lesion with different attenuation in it. And so this area in the middle here is almost certainly an area of necrosis, which tells you something about the speed with which it's progressing. We can see that her airway is starting to be compressed. And if I had the ability to scroll upwards through these images, you would see that more proximally her trachea becomes really quite compressed. That was biopsied and had a monomorphic post-transplant PTLD. It was EBV positive. It was most closely resembling a diffuse large B-cell lymphoma, but unusually for DLBCL was CD20 negative, which is relevant because that is, of course, the cellular target for rituximab. It had an Ig-MYC translocation. So we gave her rituximab and chemotherapy straight away because of her speed of progression. And she responded for about 5 days very nicely. And then she represented in serious problems with a mass protruding out of her sternal notch in the space of about 48 hours. While we reconsidered what we're going to do and got her re-imaged, she woke up in the middle of the night, essentially, well, superior vena cava obstruction, obstructing her airway, and really actually very, very nearly died. We gave her much more intensive, although still not full intensity chemotherapy, and she responded very well to that. Then it came back again, and she had kind of not a whole protocol, but bits of a full intensity sporadic protocol in drugs called CIVE. She responded to that, but then it came back again, and we gave her our standard relapse chemotherapy, which is ICE, and then consolidated her with radiotherapy. And I think she's the only patient that I've ever given radiotherapy to for PTLD, so that's not a common approach. And after all of that, she went into a sustained remission. Sadly, she subsequently died from, I think, a rejection episode. I mean, it's kind of hollow to say it, but you know, it was possible to get control of the PTLD. Okay, so that's kind of how we view it and how we deal with it. Far better would be that we don't have it. It's not a problem for our patients. And so just briefly to mention what we're doing to think about that, and our approach here in Newcastle has been to try and identify and understand in detail the risk factors and think about which of those we might be able to modify. So we know that EBV is important. What we don't really understand is how we might use EBV immunity to improve our patients' care. So you'll know that there's not an established EBV vaccine available at the minute. But it was nice to see when we were having a discussion about this the other day that actually there is an ongoing mRNA vaccine trial for EBV run by the NIH in the US. I guess COVID has some positive side effects, so certainly vaccine technology development is one of those. But that's not our bag. What we're interested in is host immune response. And so I think maybe Andy just briefly touched on this earlier, but what we have identified here in our study, again, I mentioned earlier, from Newcastle, was that the time of first thymectomy being either before or after 1 year of life is significantly associated with your risk of PTLD. So patients who have an early thymectomy, so for example, children with a congenital heart disease who need the palliative procedure, are at greater risk of PTLD than those who don't have any kind of midline operation until later. So our broad hypothesis is that early thymectomy, when you add in immunosuppression following transplant, leads to an immune dysregulation, which gives you an excessive risk of not handling EBV and it progressing to cause PTLD. So in order to investigate that, we've currently got open, although now almost fully recruited, study here in the UK run between Newcastle, our colleagues in Great Ormond Street, and a collaborator with great EBV immunology experience in Birmingham, a clinical trial called Ithacor, the immunology of thymectomy and childhood cardiac transplant, from which the primary study objectives are to really understand the circulating immunity of children having heart transplants and how that changes in response to EBV infection. So it's open to any child up to the age of 18 who is listed for a heart transplant, and then we have a small control group of children having renal transplants, and we're excluding children who have a known either inherited or iatrogenic immunodeficiency, so nobody with cancer, nobody's had a transplant before, etc. And we're taking blood samples from them pre-transplant, and then at several time points following transplant, we're looking in detail at EBV serology and viral load through PCR. And then within the academic structures, we've developed a high-dimensional, essentially flow cytometric assay, able to pick apart more or less all of the immune subsets within the peripheral blood, including EBV specific tetramers to look for EBV specific T cells. And those data are going to be paired alongside functional data using an ELISpot assay, which looks at response to EBV in the T cells in the sample. So that study is now essentially fully recruited, because of the time frame in follow-up. There's lots more blood samples still to be collected, and so a little while before we have meaningful data to present, but we're very excited about that, and I'm really pleased to have got to the end of the recruitment. So I'll stop there. Happy to take questions, but just say a big thank you to all the people who have helped with Ithaca, including Zdenka and the team at Freeman Hospital. And thank you again for the opportunity to speak to you, and yeah, happy to answer any questions. I'll just unshare. There we go.
Thank you, Simon. That was fantastic. We have a bit of time for questions. I think we have 7 minutes left. I can, while we are waiting for others to ask, I can ask one question. We have heard that thymectomy and the presence of congenital heart diseases are risk factors for PTLD. I would like to ask, what's the effect of induction treatment for the PTLD occurrence? Perhaps this is a question for all audience and maybe more for Professor Debshande.
I can take a dig, but it would be nice to hear everybody's perspective. I think the early data had suggested rather that the data is actually not convincing either way, right? We have data that has suggested that if you use induction therapy, you are more likely to get PTLD within the first 5 years after transplantation. When those studies were done, it wasn't very clear as far as the EBV mismatch status of the recipient and donor and how that played into account, as well as the interaction between congenital cardiomyopathy patients. So that there were other factors that could have played a role with the risk profile of that patient, just in addition to the induction use. There is certainly now a more case to be made that use of, and there is a PHTS study, Pediatric Heart Transplant Society study, that also suggested the same thing, which is use of induction was associated with increased risk for PTLD. In my view, I think there is a much better approach to this, which is at the time of transplantation, are we appropriately risk profiling the patient? So those with infant thymectomy, those without. Those who are naive to EBV CMV are going into the transplant, and those who are not. Those who have essentially a low risk profile, so no preformed antibodies and lots of preformed antibodies. Once we risk stratify a patient, then we may be able to say, well, this patient truly falls under a low risk category, and I would rather not use induction therapy in this patient and maybe just start with maintenance regimen right away. Whereas other patients, we have no option. Patients who have circulating antibodies, high sensitization, ABO compatible congenital heart patients, where we may now have no option, but we do have to use induction therapy, knowing that there is an inherent risk of PTLD of about 10 to 15% within the first 3 to 5 years in this patient. So it's a calculated risk until data becomes available, but that would be our educated guess or approach at this time.
Yeah, I would agree. I think some of the historic data say yes and some say no. When we looked, we didn't see an effective induction regimen in our data set. But I totally agree. I think that it would be great to be able to move to a situation where you only give it to those people who need it, and then you know that if you are taking a risk, that it's merited, and that's fine. So we need to understand what it is that makes the risk highest, so that we can then stratify according to it.
I think if there are no more questions, perhaps it is time to tell you all thank you for the great talks and conclude the webinar.
Thank you, everyone. Thank you so much.
Thank you.
Thank you so much to all the speakers.
Thank you.
Thank you and bye.
Bye.
Bye.